Good afternoon, Flagstaff, Arizona, wherever you are, people, family, community. Thank you for joining us for this hot topic. You know that when we come to you on a Sunday, that means that there was something in our conversations over the past week that we were buzzing about. And this particular topic today, COVID-19 and its impact on Black America, this is a topic that we've been buzzing about since the announcement of the new vaccine for COVID. And so we, as the Lived Black Experience Project, you know that we come to you, we bring these topics to you to educate, inform, and enlighten. And we as people of African descent, we are concerned about our health, about our safety, about the number of Black people, not only in Arizona, but around the nation, who are being affected by this pandemic. And so here we are today to give you information from professionals, health professionals, mental health professionals, and even scientists that are going to answer questions and address. There's our special guest that are going to answer questions on COVID-19. So please put your questions in the comments so that we can get to it. So with that being said, our resident facilitator, Sister Kara House, get us started.
All right. Well, again, welcome to everyone who's joining us today. We're going to launch our conversation with a look at COVID-19, what it is exactly, and when is it going to be over. We're going to hear about Coconino County's health district overview and Coconino County's distribution and administration plans for the vaccine. Giving this presentation will be Dr. Marie Peoples. Dr. Marie Peoples, Deputy County Manager, is charged with leading justice and human services related departments. Prior to serving as Deputy County Manager, Dr. Peoples previously serves as the Chief Health Officer for the Coconino County Public Health Services District. Welcome, Dr. Peoples.
Well, thank you so much, and good afternoon, everybody. I'm just really honored to be able to present to you this afternoon. I have quite a few slides, but I am going to move through them super quickly so we can get to heart of discussions. But I'm happy to answer any questions either within the Q&A or if people want to contact me offline or at another time. I work for the county, of course, and can be reached in a multitude of ways, and appreciate any questions and any discussion. So with that, I will get started. So I'm just going to share some information on the emergence of COVID-19, what the county has done in terms of data reporting, the county response efforts, and then, of course, the crux of the conversation with COVID-19 vaccinations. And as I shared, everybody has heard lots about COVID-19, the origination. So again, I'll move through these rather quickly. But on December 31st, 2019 is when the Wuhan Municipal Health Commission in Wuhan City in China reported a cluster of 27 pneumonia cases. And from then, it really exploded on the scene and within the United States. On January 9th, 2020, the Chinese CDC reported that a novel coronavirus had been detected as that causative agent. The first COVID cases outside of China were reported January 13th, and the first US case was reported on January 20th. And here we are, almost a year later. So this data is good. It's from the CDC, as you can see there on the screen, and the data changes every single day, which has been one of the really hard things about wrapping our arms around COVID-19, because it has changed so much and evolved so much, and we're learning as quick as we put out information, it's already shifted. But as of December 20th, there were over 15 million cases in the United States. and total deaths are close to 300,000, which in my mind, as an epidemiologist and as a public health professional, I find that the majority of these deaths could have been prevented, which again is the goal of the vaccine. But it's a sad thing when we talk about public health in the United States infrastructure and how it has been lacking. So some COVID specific information for Coconino County, and I assume most people on the webinar are within Coconino County or have some relationship with the county. What you see here is a weekly chart of the confirmed cases and the rate. The confirmed cases are in green, the rate is in red, and it goes back to the beginning of August. And what you can see, and I'm not sure if my pointer shows, but with week ending 12/5, we had 904 confirmed cases just in this week. So what you see is that in spite of all of the work that's being done by many health professionals and individuals trying to do the best things that they can, is that we have not been able to get a handle on cases. And with the increase of 904, what this is starting to show is some of the Thanksgiving COVID cases, but it's just incredibly unfortunate. What you see on this side of the screen is by zip code, the breakdown of cases. And then, of course, you can see some information on our tribal communities, which have been hit incredibly hard, as have all communities of color. So here's the benchmarks that the state Arizona Department of Health Services have adopted. There's 3 benchmarks: cases, percent positivity, and COVID-like illness. And they have 3 categories of minimal, moderate, and substantial. And so in terms of Coconino County, our incident rate is incredibly high. We're at 630 cases per 100,000, which makes us have a positivity rate of almost 16%. That is incredibly high. And then our COVID-like illness, and what that means, it's other illnesses that hospitals see, such as flu-like symptoms, cold-like symptoms. Perhaps there's not a diagnosis of COVID, but it has very similar symptoms. And why that's important is it helps measure the amount of disease that's within the community, the amount of virus that's within the community. So our categories for the county are incredibly concerning. And here's just the week charts. I showed you the first one that went back through August. This goes back through the beginning of when the incident command in Coconino County was set up towards the beginning of March. And you can see we started in March, we had 32 cases per week, and then we were creeping up. And even at our peak, when the state was shut down, so to speak, when the governor had orders in place, we had 358 cases during that time. Well, as you can see, we're much worse now and have been, yet we still don't have those same protections as when we were actually shut down before. This is just some information on the testing that's been done in Coconino County by week, and I'll talk about that a little bit more. And so now I'm going to spend just a few quick minutes on Coconino County's COVID-19 response. I could not be more proud of Coconino County's response. We have really, and by we, that is the collective we, whether I'm talking about individual organizations, City of Flagstaff, NAU, Coconino Community College, there's just tons of organizations that fit within that collective we. But the county itself, in terms of county leadership, has really been, again, a leader in this space. And I'm really proud of the emergency operations teams, as well as the health and human services teams. On March 11th, the state of Arizona declared an emergency for COVID-19. And just quickly following that, on March 16th, Coconino County operated and stood up the first drive-through specimen collection site. That was no small task. And I share that because not only has it continued to be incredibly important, but we have continued to lead in terms of being the primary testing space, not just for Coconino County, but all of northern Arizona. And for me, that fits into this conversation as we talk about African-American communities primarily, but also other communities of color and how those resources really have not been designated in northern Arizona. And so to be able to be in that space for communities of color has been quite important. So again, that first drive-through testing site was set up and has continued to run, is still running today. And then on March 18th, Coconino County declared the emergency because that is when we had our first case of COVID within the county, and that's really what triggered it. Things were going on well before March 18th, but before we could have our own emergency declaration, we needed to identify that first case. March 23rd is when the county shifted from facility in person, and most of the county buildings and whatnot were closed. And so the next one that I'm really going to note here is March 19th is when the county stood up the first isolation and quarantine hotel in the state. We were well ahead of the metropolitan areas. And what this allowed us to do was to help with sheltering those in our community that did not have stable sheltering. And it also helped reduce the spread of COVID across our communities. And so there's just more of the timeline. And I'll go ahead and move through this. And so just for those of you, by now, to some degree, we've all learned about epidemiology. And so if you're hearing on the news, surveillance, case investigation, and contact tracing and case monitoring, I won't read all of that. But if you take a glance at that, that really gives a quick breakdown of what are the differences? What does surveillance mean? How do we do that? What systems are used for that? How's the data compiled to inform the public? What does case investigation and contact tracing mean? And then, of course, once you've identified those cases, what goes into case monitoring? Because it's not done just when you find somebody who's positive and then they then become a case. You continue to work with that case throughout the individual's exposure period, throughout their contagious period, and monitoring their symptoms. Some more information on testing operations and where the county has been. Again, we stood up that first site on the 16th, and it has continued throughout today at Fort Tuthill, and is planned to continue for several months into 2021 already. And then, because we know we have such a large county, we also do mobile testing collection operations for Williams, Page, Grand Canyon, and Fredonia. And then we help set up some other testing operations for even further outlying areas. I'll move past the additional and I'll move past the PPE. We've also implemented a lot of community supports. Again, I think this is relevant to the conversation as we talk about communities of color. Social safety net has been established and set up to respond specifically to COVID. And when I share that these things are in place, it doesn't mean that that's enough. There's still a lot more social safety net supports needed. And one of the things that I find to be vastly missing is the behavioral health, mental health conversation. We know that mental health issues have been exacerbated during COVID-19 because of the physical and social isolation from others. And so that, again, is one of the things I think has been missing most from the response. Again, that collective we, whether it's private organizations, public organizations, that's an area where there still certainly is a lot of improvement that needs to be made. Housing and rental assistance, we know a lot of people are being displaced from their homes due to lack of work and other factors. And while there has been an eviction moratorium, that's not enough. All right, so there's prevention information, and I'm going to move past that and get into the vaccine update. And so what I want to share, and again, I cannot stress enough, this is evolving information. The information changes multiple times a day. So in terms of the county, we're working to put out FAQs that will be on our website and available through different community partners that we're going to push out. But what I would encourage you to do, and if you would help please share the information, people need to check back regularly because the FAQs will change. As soon as the CDC changes something, or oftentimes the State Department of Health changes something, whether it's new protocols or new information is learned, we'll also update that information. So it's a really good idea for people to continue checking back. So the first vaccines were actually shipped out today. So how's that for good timing? They were shipped out across the nation. The first vaccines to be able to come on for public use are from Pfizer and Moderna, and the health district is poised to be able to receive some of those very soon. So aside from hand washing and wearing a mask, immunization is the most effective method for preventing respiratory disease. And the goal of vaccinations is to increase that mass immunization and herd immunity, which that herd immunity is what ultimately curbs transmission. There, of course, are lots of concerns with how do we get to herd immunity, because there is a fear, which we call vaccine hesitancy, when communities are worried about getting the vaccine or just simply don't get the vaccine. And to be sure, with African African American, communities and other communities of color, there is vaccine hesitancy for a very good reason. There's a lot of historical reasons. There's a lot of government mistrust. So one of the things that's going to be incredibly important is rebuilding that trust, getting out timely and accurate information to communities of color so that we can increase herd immunity within communities of color. So who can get the COVID-19 vaccine? What the CDC and other governmental agencies have said is that eventually everyone, and that it will be free of charge. But for now, there's a very limited supply, and eligibility has been determined by CDC. And then every state, their state health department is part of the CDC's larger work group. And so states have also had some individual influence on vaccines and who are going to be priorities. So for us in Arizona, it's going to occur in phases and according to risk. And the other thing that the CDC looks at is maximum benefit to society. So does that mean we vaccinate our children, our elderly, our healthcare workers? How does that come about? So just some information there regarding the two vaccines that I noted, Pfizer and Moderna. So far, testing through clinical trials have shown that they both have an efficacy rate of around 95%. And so the timeline for Coconino County to start receiving our doses of Pfizer and Moderna, both of those are within December 20th to 31st, which is right around the corner. And again, those shipments did go out today, so hopefully they will arrive scheduled and on time. Both of these doses, vaccines, which is a little bit of a concern to me, is that they both come in 2-dose series. And so what that means is you'll need to get your first dose and then your second dose 21 or 28 days later. So the Pfizer vaccine is about 21 days later, the Moderna is about 28 days later. And so it's really hard to get people vaccinated anyway. And so it is concerning to me as a practitioner that we're asking people to come back for a second dose. And we really need people to come back for that second dose so that they have benefit of the full immunization. One of the things that's really important to note about these two vaccines is that they're fragile. They're not hardy as some other vaccines in terms of the actual storage of them. Our flu vaccines are not fragile. You can pack up your flu vaccines, you can transport them in a variety of ways to be able to deliver the vaccine. The Moderna and the Pfizer both require really cold storage. You'll see with the Pfizer, I've got their notated ultra cold storage, which means it is well below freezing. And so it does require some special shipping containers, which is another barrier to public health entities. I am proud to say that we have worked that out within Coconino County. What it means to other communities, though, is that we won't be able to distribute it as widely, and that we will be relying on people mostly to be able to either get to Flagstaff or partnering with our hospitals in the outlying areas so that they can distribute as well. So who can get it? Again, so in phase 1A, which is what the vaccines that we will be getting in the next couple of weeks, it's healthcare personnel and long-term care facility residents. And so who comprises healthcare personnel? There's been a lot of discussions about that. I don't know if you've caught them across the news or not. But what that boils down to is hospital personnel, and that can be anybody working in the hospital, everybody from your janitorial crews to your kitchen crews, which is really important because those people are essential workers as well, and they do have exposure. It's not just our physicians and our nurses that have exposure. So anybody working in that hospital setting, anybody in our long-term care facilities, our outpatient care facilities, home health care, pharmacies, emergency medical services, and then your public health workers and staff, your epidemiologists, those collecting data, the ones doing the surveillance, the monitoring, they're eligible as well. Other essential workers, which will be in phase 1B, so for the next shipments, include our food and agriculture workers, our transportation workers, so our bus drivers, our snowplow drivers, other individuals that keep our roadways clear, our education and childcare providers, energy workers, water and wastewater workers, and our law enforcement. And then in phase 1C, which will be even further down, is going to be our high-risk individuals and those age 65 and older. And then, so there's been other questions in terms of, so Coconino County doesn't have enough health staff to be able to vaccinate everybody. And that's indeed true. And all throughout COVID, we have asked for other partners. We've never wanted to be the only testing site, the only monitoring site. And so we've worked hard to build partnerships and to train others and to share those skills so that we could have a deeper bench, a deeper roster, if you will. And so part of that is being able to work with not only our healthcare providers, but paramedics, others that are trained to give vaccinations so that they can also be vaccinators and that we can share our stock and have the appropriate people vaccinated in a quicker fashion. And so through that, the Arizona Department of Health Services has developed what they call an attestation. So an organization like Flagstaff Medical Center, who is now a COVID vaccinator. They've received the appropriate training. So I'll just use Flagstaff Medical Center as an example. They had to fill out this attestation, and then they had to go through the various training modules to know how to handle the COVID vaccine and then to be able to appropriately vaccinate. So we have worked with many entities to be able to do this so that the health district is not the only game in town. And so there will be a multitude of entities that also are able to do it and will be able to vaccinate their own staff. And that doesn't mean that they get to change the rules or requirements for who's eligible for it. They still have to follow those strict guidelines that I shared in terms of who is eligible. And so just some additional information. Also, this attestation means that each facility is able to meet each requirement of holding the vaccine. Because there's such a small supply, we don't want vaccines to not be held properly or to be wasted in any manner. So that vaccine will be direct shipped to providers from the distributor or the manufacturer. There is a 24-hour reporting requirement for adverse effects. So unfortunately, with all vaccines, even your standard flu vaccinations or other vaccinations that you may get through your lifetime, there are at times adverse impacts. And so COVID does require 24-hour reporting. And that means your physician, your nurse, other individuals, if they learn of an adverse impact, they have to report it. And that will help us continue with the efficacy in knowing how well the vaccine has worked. And then there's lots of provider outreach that I'll skip over, but it's important that all that education is being done. So again, we are prepared and we're partnering with lots of people to be able to disseminate the vaccine. And we're also working on a lot of different, as I shared, the FAQs, but we're doing specific FAQs to be able to capture the adverse reactions that are known to date and as that evolves. So with that, I'm going to stop sharing my screen. And we'll be prepared to take questions at the appropriate time.
Thank you so much, Dr. Peoples. That was a wonderful presentation, and I'm sure we will have questions for you during the open Q&A. As a reminder to the community, if anyone has questions on this or any of the presentations, please remember to share them in the comments so that we can ask them during that open Q&A, which is coming up soon. Up next, we are going to hear about COVID-19 and its impact on Black America and the social determinants of Black health. And giving that presentation will be Mr. Jermaine Barkley. Jermaine Barkley has a Master of Arts in Sociology and is passionate about reducing community trauma and promoting progress through collaboration and education. He has worked in the fields of social work, criminal justice, and psychology in Coconino County for the past 8 years, and currently works for Health Choice Arizona as the first episode psychosis grant coordinator. Welcome, Mr. Barkley.
Thank you so much, Kara. Thanks for having me, y'all. And we'll go ahead and launch right in. I'm thinking, it looks like I'm sharing my screen, so we should be all good to go here. Like Kara said, my name is Jermaine Barkley, and I'm honored to be spending some time with you this afternoon to be talking about something that I think anyone concerned with health, justice, and equity in our communities and in our country should be aware of, knowledgeable about, and concerned with, and that is social determinants of health. So what are we going to go over today? Well, in our brief time together, we'll be doing the following. We'll be defining social determinants of health. We'll give some examples of what social determinants of health are and their impacts on health outcomes and metrics. We'll discuss social determinants of health as they relate to the Black community. We'll identify how the Black community in the U.S. is currently impacted by COVID-19. And then lastly, we'll bring it together by discussing the interplay between social determinants of health, COVID-19, and the Black community. Like was mentioned, there's a Q&A session after these presentations, so please feel free to comment or chat questions, and we'll be sure to stick around to address those questions for a discussion. So first things first, let's start out by discussing exactly what social determinants of health really are. The concept is fairly new in the field of research. As far as research goes, it's fairly new. However, as we discuss it a little further, I think it'll seem more like common sense to folks, even if you hadn't heard of it previously. Now, of course, there are a lot of different factors that contribute to our individual health, be it mental health, physical health, or what have you. And if you were to stop someone on the street and you were to ask them, okay, what factors contribute to someone's health, be it poor health or well off? You might hear someone say first that their biology comes into play, so their DNA, what runs in the family. Perhaps diabetes runs in the family, and it puts them more at risk for developing diabetes later on in life, etc. Then you might get to the next layer or level of individual choices. So does that individual exercise? Are they healthy? How do they eat? What do they choose to put in their body? How often do they see a doctor, and how seriously do they take that? And at face value, these sounds like pretty individual choices, right? Person has free will. They can choose to be healthy or not. They can choose whether or not they go and they eat fast food every day, or they cook their meals at home. They can choose whether or not they go to see their doctor, etc. At face value, it seems like that's a 100% individual choice, and it would make a person 100% responsible for the outcome of their health as a result of that. However, what's often missed in the nuance of that conversation is just how our social environment contributes to those decisions. So the fact of the matter is, it's a bit of both, yes. So it's a bit of biology, DNA, individual choices, but it is also a bit of our social environment. And we often downplay how big of an impact those social factors can have on a person's health outcomes. So think of it from the framework of a nature versus nurture debate. So of course, genetics are going to come into play, but to a large extent, so does the environment, which helps define and cultivate how those genetics play out. Social determinants of health are conditions in the environment in which people are born, that they live, where they learn, work, play, where they worship and age and grow old, that all affect a wide range of health, functioning, and quality of life outcomes. Unfortunately for us, we don't generally get to choose the circumstances in which we're born, and oftentimes the environment in which we live in is partially a result of a lot of factors that are being impacted outside of our immediate control. What neighborhood we were born into, the quality of education system we were exposed to, the amount of violence in our communities. All of those things are larger systemic factors that we don't immediately control or impact, but they have an impact on our health nonetheless. What research is showing is that things like the type of neighborhood where you live, your economic status and how much money you make, your access to health care, the quality of your education, and your community overall can all have major impacts on your actual physical health outcomes, for better or for worse. They can correlate to your risk of developing heart disease later on in life. They can correlate to developing chronic stress, which has a multitude of other health risk factors that are associated with this. So on this slide, you'll see just a few different categories of social determinants of health that have been found in research to contribute to health outcomes. So economic stability, neighborhood and built environment, health and health care, education, and social community and context. And we'll get into defining what each one of those are in a little bit more detail in just a second. So let's take a more specific look. On your screen, you'll see a chart from the Kaiser Family Foundation that breaks down some common categories of social determinants of health that have a profound impact on health. So as you can see, examples of social determinants of health include things like the availability of resources to meet your daily needs. Do you have safe housing? Do you have hygiene capabilities, a shower? Do you have grocery stores and food markets? Access to educational, economic, and job opportunities. How much money are you making? What jobs are immediately available to you? Access to healthcare services. And that's not just healthcare. Right now, healthcare is a big public and national conversation, but it's also in relation to, do you have doctors in your immediate community? Do you have doctors that are culturally competent? How long does it take to schedule a doctor's appointment? And how long does it take to get to that doctor's appointment? Coconino County is actually in one of the areas defined by the federal government as having too low of a ratio of primary care physicians to our overall population, meaning there are a lot of folks who just can't get in to see the doctor sometimes. Quality of education and job training is a big one. Availability of community-based resources in community living and opportunities for recreational and leisure time activities. So does your neighborhood or city have a YMCA? And is it affordable? Are there sports leagues for your kids to participate in? Are there parks that are safe, that are well kept by the city that your kids can take advantage of? Things like that all contribute to your health as well. Transportation options, which we'll get into in a lot of detail. But just to kind of touch on last presentation by Dr. Peoples, one of the conversations that we have to have is because of the kind of finicky nature of transporting the vaccine currently, and because it looks like we may need some folks to travel to get that vaccine, social determinants are going to become a huge conversation, right? Not everyone has a car. Not everywhere in Coconino County has an available bus route. The Greyhound doesn't even run everywhere in Coconino County. And so it's going to become a conversation of how do we make sure everyone is getting fair and equal access to treatment. Public safety is a big one. Is there a lot of community violence? Because that can result in chronic stress. Social support, social norms and attitudes. So again, like's been mentioned not only in this presentation here, but in our Live Black Experience presentations in the past, people of color have a pretty jaded relationship when it comes to the medical field and the government in our country, because of things like the Tuskegee experiment, and a multitude of mistreatment by our systems. And so that's going to come into play when it comes to how often and how willing are we to access healthcare services. Exposure to crime, violence, and social disorder are a big one. And that's not just gang violence. It can be police violence. And it's not just physical violence either. It can be things like trash, lead in your paint still. You think of a place like Flint, Michigan, where there's lead in the water. It can be a lack of cooperation in the community to address these issues. Socioeconomic conditions like poverty and stressful conditions that accompany it, like being at risk of being evicted and now living out on the streets, or being food insecure and not being sure whether or not you're going to be able to have a substantial meal for you and your family. Residential segregation, things like redlining. You know, if we could spend all day talking just about the impacts that redlining has had on our people in the U.S. Because neighborhoods and property value dictate the amount of resources that go into a community, which is going to dictate the quality of your parks. It's going to dictate the quality of your public transportation. It's going to dictate the quality of your education system, which is going to dictate perhaps the quality jobs that are going to be in there. And it snowballs into this cyclical cycle of oppression. Also impacts our health. Language and literacy are a big one. Our health services inclusive when it comes to individuals who speak other languages besides English as a first language? Are individuals in a position where they can understand the literature and information being given to them? And is it being given to them in a culturally appropriate and understanding way? Access to mass media and emerging technologies is a big one. Some places don't have great access to things like the internet, cell phone service, and we often take that for granted. It is not necessarily the best thing in the world to get your information from social media, but imagine living in an area where you don't get good service and you don't get good television service. How are you keeping up on information about the vaccine? How are you keeping up on information about COVID-19 protocols when you live in an area where you don't have access to mass media? And then culture comes into play as well. So the question that we have to ask ourselves becomes, to what extent are these factors impacted by an individual? And what extent are they impacted by their environment? I don't mean to open a can of philosophical worms here, but I think that the concept of the American dream teaches us that no matter what, with enough individual will, we can render some of these social impacts ineffective, right? When it comes to their negative impact. And through our will and our hard work, you can overcome and rise above. And that's a great message, but if we're being honest, a lot of these outcomes are systemic. They're a consequence of the systems at play in our country, in our communities, the availability and distribution of resources, and the priority of our policymakers and systems. Access to healthcare and healthcare services, public safety, the quality of your housing, quality of education, and more are all these huge systems that we live in and we try to operate under, either with or despite. And although we might have little say on how those systems are constructed and operated, we still have to live with them. Ask yourself, when is the last time you were consulted about your school district's curriculum and education, or perhaps the specific amount of funding that your education system was getting, or the distribution of community development dollars and where that goes specifically, or the amount of dollars that goes to your county in general? When is the last time you had a direct say in how many doctors are going to be in your county and in your city, and what quality of healthcare they're going to have and what training they're going to have? A lot of these things happen outside of our individual control, and these things still impact our health. So I took the liberty of coming up with an example case study. Try not to feel too bad for Billy. Billy is a figment of my imagination for the purposes of this presentation. So Billy's a 14-year-old boy who lives in a low socioeconomic neighborhood. His mother works 2 jobs and doesn't currently have her own transportation, so she takes the bus to work each day, meaning she's often gone super early in the morning, and she comes home pretty late. She didn't complete high school. His father's not currently present in his life, so the family struggles to pay bills. Billy lives in a county that has an extremely low ratio of doctors and primary care physicians to the population, so it's kind of hard to get a doctor. Furthermore, his school district is ranked towards the bottom of the state's list on education, and the school suffers from overcrowded class sizes. Billy's neighborhood also sees a problem with crime and violence, and while Billy himself does not get involved in gang activity, he is exposed to gang violence on almost a daily basis. So in this example, Billy obviously is not in the best of situations, right? But he isn't in an exactly super foreign situation either to really any state or county in the country. So let's take a moment to discuss how these situations would impact his health. For one, children who are born to parents who have not completed high school are more likely to live in an environment that poses barriers such as a lack of safety, being exposed to garbage and substandard housing. They're also less likely to have access to things like sidewalks, parks, playgrounds, recreation centers, or even a library. There's been other evidence and studies that show that stress, of course, negatively affects health across your entire lifespan, and that environmental factors have multi-generational impacts. It gets passed on. So in Billy's story, he's being raised in a high-stress environment, and chronic stress is known to have extremely detrimental impacts on your health. Just as well, their income level is going to severely impact the quality of things like the food the family can afford, as well as how often they can afford it. Often when we discuss eating healthy, we forget about the barriers to doing so, right? So not only is cost a barrier in this scenario, but so is transportation and time. Does this family have the time to meal plan and make it out to the grocery store? Do they take the bus when they go? How often does the bus route run on the path to the grocery store? And does the neighborhood even have a grocery store that sells healthy food? There are some places in the US that don't. And so the issue of transportation is a huge one. Can they make it to doctor's appointments on time? How close is the nearest primary care physician? Regarding education, does Billy recognize a health problem when he sees one? To what extent has he been informed about health risk factors and red flags? What's hard about these things is they tend to go together, right? Being exposed to violence or not completing high school or not having quality education can impact things like social skills or what career you get. And that can impact your level of pay, which can dictate your socioeconomic status, which can impact the quality of your housing, which can impact the environment that you live in. And low-income neighborhoods with less taxes coming in generate less public services for parks, libraries, schools, and extracurricular activities. Even the quality of water, the presence of lead are all associated with your environment, and those severely impact your health. So in Billy's case, he didn't choose any of this, right? It's cyclical, and he's living with it all the while it's having an impact on his health. Stress is associated with heart problems, blood pressure problems, chronic pain, and depending on the coping mechanisms he picks up to address these things, they could either be healthy or unhealthy. So his outlook on the importance of medical care could also be impacted, right? Whether or not it's even accessible is an entirely different question. So you see, maybe his family genetically sometimes is the picture of health, right? They don't necessarily have things that have run in their family genetically. And maybe they make an effort to try and be healthy, but there are still these huge overarching social factors that still impact their health. So the question is now, how do we as Black Americans fare in social determinants of health? Unfortunately, if the answer was, hey, we're doing great, we're great in all these categories, we probably wouldn't be here, right? The story of social determinants of health in Black America is a story of disparities. And we'll start here. So Healthy People 2020 is an American firm and research organization, and they came up in their research with 5 key areas of social determinants that have a really big impact on health in 2020. And those areas were the one we saw earlier on our screen: economic stability, education, social and community context, health and healthcare, and neighborhood and built environment. So what you'll see on your screen are examples of what falls under each of those categories. So some examples: income, employment, early childhood education, discrimination, access to healthcare, crime and violence, quality of housing, all areas wherein we as the Black community historically and still see huge disparities. There are some states and organizations that are currently listing racism as a public health crisis after we've seen the huge impact that systemic racism is having in our community and on our life expectancy. We're more likely to be paid lower wages for doing the same job. We're more likely to live in lower income neighborhoods, which means less likely to have access to health care or access to services, and less likely to have access to healthy food even. We discussed in our community discussion series for the Live Black Experience the impact that the stress of racism has on the Black community and our health and well-being. We're also more likely to report unfair or unequal treatment in doctors' offices, and Black women in particular are more likely to be given inadequate medical care in comparison to their white counterparts. So the fact of the matter is that systemic oppression that has stained our history in the US is literally killing us. It's a health risk to be Black in the US, and it has a lot to do with the social systems we so often see discrimination in: housing, education, career opportunities, income, policing, what have you. And here's the thing we have to keep in mind. Improvements regarding equity to these systems, they benefit everyone. As we'll see on our next slide, there are other populations that are also suffering pretty disproportionately from COVID-19. And so while we're speaking about this from the Black experience, our lived experience, it's in the best interest of all of us to strive towards closing the gaps that you see on your screen. So then let's talk more specifically about COVID. Nowhere has the gaps in the social determinants of health been made more clear in recent times than the outcomes as they relate to COVID-19. Now, I want to make clear that any loss in this pandemic is absolutely a tragedy, and it should be treated as such, right? Because it's not a competition. Many of us have lost someone near to us this last year, and the country is still reeling from a raging pandemic that could have had its impacts prevented to some extent. Yet this crisis has once again exposed huge gaps in our system, in our communities, and in the Black community specifically. So here you'll see a chart from the Center for Disease Prevention and Control from the CDC that breaks down the rate of cases, hospitalizations, and deaths compared to that of white Americans. They use white Americans as the benchline here. And as you see, we, as well as our Native American and Hispanic Latinx community members, are almost 3 times more likely to die from this virus. 3 times more likely. 4 more times likely to be hospitalized. And here's the kicker. So while this chart kind of shows that some populations are more likely to catch the virus, there have been several studies that have been published recently that contradict that evidence, that say that we're not more likely to catch COVID-19 as our white counterparts, but we're still more likely to die. Still more likely to die from it. Virtually the same amount of people are contracting the virus between these populations in some of these studies, but still they also see 3 times the deaths in these studies. So what is contributing to the disparity? I mean, look, the answer to this question is pretty simple. Thus far, we've kind of touched on it a lot here. The social determinants of health that have been impacted by systemic racism and oppression directly contributes to our health outcomes. And that doesn't mean COVID-19 is immune to this, right? COVID-19 is a great example of this. With COVID-19, it's about exposure to the virus, right? It's about where people work, where people live. It's about what kind of jobs people work that put them at risk and whether they can afford to miss those jobs. It's about how many people live in your household and whether or not you can adequately distance if someone catches COVID. Something else of note is that because of the system we just discussed, we as African Americans, as Black people, are more likely to have underlying conditions than our white counterparts. And therefore, when we catch COVID-19 in our community, the impacts can be far more severe. Race is a social construct, right? Therefore, we're here discussing social determinants of health, not biological ones. The fact of the matter is that this disparity in deaths is avoidable had we as a nation taken the necessary steps to acknowledge and address the gaps in our systems. Then perhaps we wouldn't see such a huge difference when it comes to mortality across race. It isn't until we address prejudice, discrimination, and bias that we'll see better health outcomes. And until then, our community, the Black community, is left fighting an uphill battle where we're not only fighting for our physical health, but we're fighting against these systems that don't have our health in mind currently. The second half of this conversation eventually has to be, how do we address these disparities, not only from a perspective of doing what is right, but for dealing with a public health crisis? Because until we make great strides in these systems, until we make great strides in promoting equity and achieving justice, these disparities in our health will always exist. I've included some links, and I believe I've stopped sharing.
Thank you so much, Jermaine, for that information. And we look forward to engaging with you more during the open Q&A. As a reminder to our audience, we've seen some ask questions already, and we encourage folks to continue posting questions in the comments for the upcoming Q&A. Now we're going to hear a bit more about the research and the vaccine from Mrs. Amber Jones. Amber Jones received her Bachelor's of Science in Biomedical Science with a chemistry minor and her Master's of Science degree from Northern Arizona University. She has actively engaged in scientific research from her time as an undergraduate research assistant to her current position as the research coordinator for the Pathogen and Microbiome Institute at NAU. Amber is also a member of the African American Diaspora Council and volunteers with the Postpartum Support Line of Arizona. Welcome.
Thank you for having me. I'm so excited to share this information with everyone. So let me pull up my presentation. So a lot has happened in this past year is probably an understatement. So I really wanted to dive into the COVID-19 vaccine and just vaccines in general. So what I will be going over are kind of the basic biology. So how do vaccines work? And focusing specifically on the mRNA. So we have heard a lot about messenger RNA vaccines because the two leading, Moderna and Pfizer, these are both their as they're both of what they've created are these messenger RNA vaccines. And then I'll cover kind of the development and approval process that typically happens, and then address the COVID-19 vaccine specifically because it is pretty unusual in several accounts. And I hope by the end I can give everybody enough information to understand how it came together so quickly. We had a vaccine in less than a year, which is just incredible, and discuss whether or not it's safe because of how quickly it happened, there's definitely some questions about safety. So I'm hoping that I can give everybody the information to address vaccine hesitance and be able to communicate this further on. So starting with vaccines as a general overview, we're all very familiar with them, but did you know that they're the most successful public health initiative? So it is estimated that 3 million deaths are prevented a year due to vaccinations. For example, wild polio has been eradicated. There's roughly 2 remaining endemics in the Middle East at the moment. Smallpox has been eradicated. Measles, which has a very high infant and child mortality rate, is down 73% due to vaccinations, which it's estimated that has prevented 23.2 million deaths. And tetanus, something that we don't necessarily think of unless you're, walking around some rusty nails. Maternal and neonatal tetanus, which has 70 to 100% mortality rate has also been addressed through vaccines. And then this last point has several vaccines that we're all familiar with, hepatitis A and B, rubella, mumps, influenza, chickenpox, HPV, which is the human papillomavirus, yellow fever. It's really incredible what we've been able to do with vaccines. And so the idea behind a vaccine is to introduce a piece of the pathogen. So pathogen is any microbe that's going to invade your body, take over your cells to replicate themselves, get out of your body, and then go infect somebody else and do the same thing. So it introduces a piece of that pathogen into your body to trigger an immune response. So we want your immune response to build antibodies, which are kind of these, they're kind of flaggers. They know how to identify the pathogen and then mount an appropriate response from your immune system. And what we really want to get to is that herd immunity that Dr. Peoples talked about. So this happens when enough people in the population are immune to a disease-causing pathogen to restrict transmission. So right now we're seeing rapid transmission between individuals with COVID-19. So what we want to get to is a point where enough people are immune to it that it can't continue to jump from person to person. And this is really a fantastic idea because you don't need 100% of the population to reach herd immunity. It's usually within 80, 90, 95% of the population needs to be immune. And that in turn helps protect the people who, if they were to contract a pathogen, that would be a death sentence. So think like immunocompromised individuals, the elderly. So it's a really fantastic way. Oh, and infants too, because they're not able to have their immunizations until later. So it's a really fantastic way to help ensure that our population is healthy. So here's a quick overview. I couldn't help myself. I thought DNA and RNA with eyes were too cute to pass up. So you have this protein production. This is a central dogma in molecular and cellular biology, is that you have your DNA, which encodes for all the proteins that your body needs to make. And proteins are important because they're kind of like the machinery of this of your cells. So they're the ones carrying out all the day-to-day functions and therefore help propel you throughout your day. So all the blueprint is in the DNA. That DNA resides inside the nuclear envelope. It has to be transcribed into a different language before it can be turned into protein. So you go from your DNA, it's transcribed into RNA. So this is where our messenger RNA comes in. So it's been translated or transcribed into a different language, and then it leaves the nuclear envelope, hooks up with some different machinery, which reads the messenger RNA and builds the protein as it reads the messenger RNA. And so this is where you get this really fantastic, big pieces of curlicue, super crazy proteins that are so essential to life. So here is an artist rendition of that. So if you see the kind of like Swiss cheese moon looking thing, that's the nuclear envelope. And inside of it, you see that double helix, our wonderful DNA. And so what happens is inside that nuclear envelope, the DNA is transcribed into messenger RNA, and you can see that messenger RNA coming through those pores. And then they hook up with this kind of red blob. I'm going to spare you biological names, but it's essentially, it will read the messenger RNA, and you can see this little kind of string with beads on it. That's our protein. So as it's reading the messenger RNA, it's building those proteins. So let's look specifically at SARS-CoV-2. So this picture is an electron microscope picture of the actual virus itself. It belongs to the family called coronaviruses. It's a big family, and most of them circulate in animals. So most of them do not jump into humans and make us sick. It's actually it doesn't happen very often. So zoonotic infections, those that infect animals, they are primed to infect that animal, reproduce, and then move on to the next animal, so continue to reproduce. When it gets into a human, it doesn't have the right machinery to enter the cell, so typically, it doesn't do anything. Occasionally, especially in areas where you have a lot of human and wildlife overlap, you tend to see these spillover events. And this is when, like SARS-CoV-2, it was doing really well in like bat populations, It ended up jumping into humans and unfortunately was very successful at replicating and spreading. This isn't the first time that we have seen SARS-CoV. In 2002, we had the first one emerge. So this is SARS-CoV-1. And 2 years later, we had MERS. And we also had a resurgence in 2012. So there's been a lot of research done on coronaviruses because SARS and MERS both had kind of like these markers to indicate that they could potentially be pandemic. They could be like these super spreaders and cause a pandemic. So there's been a lot of research done into them. And then, of course, the introduction of, or the spread of COVID-19 in 2019. And I want to mention that these viruses don't contain DNA, they're RNA viruses. So if we go back to that, if we go back to this, so instead of having that double helix to store all of its information, it has that single strand of RNA, which is really important when we come into our messenger RNA vaccine. So here's another representation of that, of SARS-CoV-2. You see those spiny projections. So not only does it give the virus its name, it's also really important for cell entry. So like I said earlier, viruses, other pathogens, they need to get into your cells in order to hijack the machinery to then replicate themselves. Once they do that, they kind of explode out of the cell, they move on to other cells. They eventually make it back into the environment and go on to infect somebody else. If you have a big enough infection, if there's enough of them causing, like wreaking havoc on your cells, that's when you start seeing the symptoms. So what we really want to do with these vaccines is be able to identify them so our immune system takes care of them before we see any symptoms. And so spike proteins are a primary antigen-inducing immune response. So what that means is that our immune system is really good at mounting immune responses to spike proteins because SARS-CoV-2 isn't the only virus that utilizes these spike proteins. So with the messenger RNA vaccine, what you have is that genetic material that tells the cell how to make a spike protein. You cover that in a bunch of lipids so the body doesn't deteriorate it as soon as it's injected into your body. And it helps deliver this microRNA strand into your cells. So once that microRNA has entered your cells, so the muscle cells, your body will start producing the spike protein. So the spike protein doesn't do anything by itself. So the cells produce the spike protein. It's moved to be presented on the outside of the cell, similar to what we see with this virus. The cell puts it on its surface and the immune system cells come by, recognize it as a foreign body, and initiate an immune response to it. So they will build the antibodies to it and then degrade it eventually. So I want to go back to this, our fantastic little drawing of protein production. So one piece of misinformation that I have heard personally is that the messenger RNA will come into your cell and alter your DNA. That's not true. So this nuclear envelope, the Swiss cheese looking moon around the DNA, it's selectively permeable, which means like only certain molecules are able to get in. And the messenger RNA is not one of them. It can definitely come out of the nuclear envelope, but messenger RNA coming into the cell cannot then go into the nuclear envelope and start messing around with the DNA. So I wanted to address that because that has come up. All right, so new vaccine development typically follows these steps. So you have an exploratory stage. It's a lot of basic biology research, a lot of like wet lab work where you're testing your theories. And once everything is safe in that exploratory stage, you move on to the preclinical stage. For vaccines, this typically requires like an animal model. So typically mice. So if it looks good in the mice, then they'll move on to the clinical development once it's deemed safe to use in individuals. In the clinical development stage, you have these three main phases, and I'll cover the fourth in a minute. But phase one, you're testing your vaccine on a very small group of people, and you're looking for any adverse effect at that point and some efficacy at this point. If that goes well, then phase 2 happens, and you start to bring in more people. You have a larger sample size, and there's really a focus on diversity. So they want to see how this vaccine is going to affect individuals in all the populations that will eventually be receiving the vaccine. So they want a large group that reflects the general population in phase 2. In phase 3, we have a much larger group. So now we're talking like tens of thousands of participants at this point. And so they're testing for efficacy and safety. So efficacy is, how effective is this vaccine in real life? How well does it work at preventing COVID-19 infection? And how well does it do in limiting transmission? And then there's this optional phase 4, which some trials can continue after approval and licensing, and it's just continuing the randomized trial. So, you have a group that's receiving a placebo, it doesn't have anything, and then you have a second group that's receiving the vaccine, and you compare the two. There's some ethical questions that come up with phase 4, and it's come up now especially. And that's just, if you have an effective vaccine, what are the risks of not giving it to the placebo group? So that's a kind of some questions that are going around at the moment. After all the clinical development, then we move on to regulatory review and approval, and I'll talk about the agencies that are involved in that in just a moment. And then, of course, manufacturing and then quality control. And while I have this slide up, I want to talk about quality control. It's super important. So it's really important to be testing each batch of vaccine that's coming out. So some of you might have had like an adverse reaction to vaccines in the past, and it could very well be related to quality control. So for instance, there have been instances where batches haven't been tested, and it turns out that the batches that haven't been tested were not inactivated correctly. So that was back when viruses were grown up. Think like the influenza, where it's injected into an egg, it's grown up, it's inactivated, and then the inactivated virus is presented into your body through the shot. So if quality control is not like strictly being controlled, then you can end up with, a batch of live virus that then makes somebody very sick. And that is really detrimental to the relationship with the public and the trust with public health agencies. So that'll be something to look at as we move forward with all these new vaccines that are coming out. So the vaccine product approval process is regulated by the Food and Drug Administration, the United States Food and Drug Administration, specifically their Center for Biologics Evaluation and Research. So there's a few applications that drug manufacturers need to apply for. There's another set of clinical trials, and then there's manufacturing inspections. And then once that's all done, it goes through an approval process. And so that's the FDA's Vaccines and Related Biological Products Advisory Committee. Once they deem that it is safe and that the risks or the benefits outweigh the risks, then they move on to usability testing and product labeling. So once a vaccine is approved, there is this this board, or actually it's a surveillance program. So this vaccine adverse event reporting system, it's a co-sponsored by the CDC, so Center for Disease Control, and the FDA. So they're the ones that are tracking all the side effects. So as we move on and the vaccine starts to roll out and we have more people taking it, they'll be tracking the side effects. So as time goes on, we will know more information regarding side effects. And so a lot of us have heard about the emergency use authorization that the FDA has for vaccines. It wasn't Moderna, Pfizer has received this emergency use authorization. So basically what it does is it streamlines the process a little bit, makes the government a little more flexible in taking a drug or a therapeutic and or distributing it to the population in what's the word I'm looking for? In times of emergency. So definitely getting a vaccine out during a pandemic is an emergency, and that's why this emergency use authorization for vaccines has come up. So this can only be applied for after phase 3 trials. If it's not, there's a little bit of wiggle room. they would have to have interim analysis and have at least, actually well more than 3,000 participants in their database. So both Moderna and Pfizer have done this, and I'll talk a little bit more about that coming up. But just to hopefully put some fears at bay, the quality of the vaccine is still there. So these developers still had to go through really stringent process to get to this point. And then, of course, the potential benefits have to outweigh the known and potential risks before it can be approved. So we have our two leading vaccine developers. We have Pfizer and Moderna, and this is kind of the breakdown of their phase 3 trials that wrapped up not too long ago. So 43,000 participants for the Pfizer, 170 developed COVID-19 symptoms. Of that, 162 were from the placebo group, so they did not receive the vaccine, and then 8 were in the vaccinated group. It was deemed to be 95% effective, which is fantastic. It is 94% in those 65 and older, but overall, it was well tolerated. They reached all of their safety milestones before applying for that emergency authorization. And I would like to note that 3.8% did report fatigue and 2% reported a headache after receiving that vaccine. And so looking over at Moderna, they had 30,000 participants, 196 of which developed COVID. Of that 196, 30 were severe. So they had a severe case of COVID-19. It was deemed 94.1% effective. So both of these are incredibly effective, considering that, in some years, depending on how influenza is going, it can be like the flu shot can be 60% effective. So this is incredibly effective. And like I said, both of them reached those safety milestones. I think Moderna actually went 2 months longer than the required emergency authorization requires. Pfizer has been given that FDA emergency authorization, and we heard that it's being shipped today, which is so exciting. And Moderna is still waiting as of today. So how did it happen so quickly? There's a lot of talk about this because typically it takes years to develop a vaccine. So we're thinking like, in the past, it's taken like 10, 15 years to develop a vaccine. So I want to start with Operation Warp Speed. So this was a collaboration between the Department of Health and Human Services, the Department of Defense, and the private sector. So think like research institutions and manufacturing and all. So it was this coordinated event, and they took information from their experience with the Zika outbreaks not too long ago. So if you remember, Zika is typically in the southern hemisphere, and it was mosquito transmitted, and it gained a lot of publicity because it had these really terrible effects on fetuses if the mother were to be infected with it during her pregnancy. So they had this group called the Zika Leadership Group. It was between the National Institute of Health, the NIH, and the Assistant Secretary for Preparedness and Response. And so they took that because there was a big push to figure out, how can we develop a vaccine quickly for Zika, and how do we distribute it? So they had a lot of experience just with that they applied to Operation Warp Speed. And their goal is to deliver millions of safe, effective doses of SARS-CoV-2 vaccine by next year. And so one of the things that they really focused on was speeding up the time to trials, which can be pretty time consuming. And so you have this coordinated effort, but there were also other points to consider with how this came together so quickly. So messenger RNA as a vaccine or a means of delivering, I'll stick with vaccine. So messenger RNA as a vaccine has been studied for decades. So this isn't new technology. They didn't have to reinvent the wheel in several instances. So you have decades of research. We know how to make it. It's also less expensive and faster to manufacture than other versions of vaccines. So I'm going to go back to the influenza vaccine, where you would have to inject it into a chicken egg, and then you have to wait for it to grow up, and then you have to there's a lot of waiting, and then to be able to scale that up is very difficult. It's also safe and effective. So the nice thing about that messenger RNA is you can take the genetic code to build that spike protein. And you can, There's nano delivery, technology now. So the messenger RNA isn't degraded before it gets to the body. So it's safe and effective because you're not, injecting that live virus or that inactive virus. And we have a lot of data about how effective they can be in mounting a response. There's also a lot of research on the coronaviruses that I was talking about before. So again, since 2002, we've been studying SARS-CoV-1. And so given that the names are very similar, it's safe to say that they are very similar. So we had that data. So again, they're not reinventing the wheel. They're not starting from scratch. They have a lot of data to fall back on. And sequencing the spike protein, sequencing anything has become incredibly cost-effective and very fast. So thinking, 20 years ago, before it was incredibly expensive and laborious to try and get a sequence. And what I mean by sequence is the base pair. So you're looking at each base pair in DNA to see what's the code for, again, the spike protein. What are all the A, C's, T's, and G's that you need to build a spike protein? It's really inexpensive. So, and this happened really quickly after the first wave. So for instance, TGen here, or TGen North in Flagstaff, they now have over 3,000 complete genomes for SARS-CoV-2 that they took from patients, positive patients. So it doesn't take a lot of time or a lot of money relatively to sequence the spike protein. So once everything once the pandemic really started, they had sequencing data. They knew what that genetic code was. And then they could go back on the research of, how do we make these messenger RNA vaccines with this code for this particular spike protein. And then back to that collaboration, there was a lot of funding that was provided for these. So Operation Warp Speed had quite a few contracts, and they distributed $6 billion to get vaccines developed. 1.79 billion went to Pfizer and 955 million went to Moderna. And it wasn't just the manufacturing groups that received funding. The government also invested in manufacturing so that these drug developers didn't have to take on that additional uncertainty. So all of that. And then finally, I want to touch on the clinical trial participation. So as we know, especially for those phase 3, there's a lot of participants that need to go into it in order to deem it safe and effective and then distribute it to the general population. So with it being a pandemic, this has all of our attention. And so I think once they finally had, the vaccine trial ready, I feel like it was probably pretty easy to get participants and to keep them because they are monitoring them over several weeks. To make sure that it is effective. So I think with that, they were able to, find and retain participants for clinical trials that may have not happened as quickly in the past. So is it safe? I would say yes. It has been rigorously tested and it's incredibly effective with that 95 and that 94%. It's incredibly effective. I will say, please talk to your physician if you have a history of allergic reactions. So there is risk in receiving vaccines. We know this from previous years. When you go in to get your flu vaccine, it's asked are you allergic to eggs or something? At one point it was that, but it's just be aware if you have a history of allergic reactions to talk to your physician. We've seen in Pfizer in the UK that there has been some adverse effects, and we'll start to know those more as time goes on too. So as these are rolled out in phase 1 and phase 2, we'll start to get a better idea of what the adverse effects are because, you do have that phase 3, but it still doesn't include everybody. So you might have people who, after it's been accepted, have adverse reactions. And like I said, we'll know more as time goes on. Definitely talk to your physician if you have any questions. This has all happened really quickly. Science is not typically a fast industry. It usually takes a lot of time, a lot of validation and everything, but I think this was kind of the perfect storm of we have the basic understanding really well with the years of research in coronaviruses and with messenger RNA vaccines. And then to have this joint collaboration of so many different departments in the government and, the private sector, that it really came together. This was definitely really incredible to see this happen in real time. yeah, there is still still a lot that we don't know, but we will know more as the months go on. Definitely check CDC. They have good information, and yeah, definitely stay tuned in because this story is unraveling day by day. So saying that, and I guess I want to mention really quickly, I was really excited to do this presentation because there is, this lack of mistrust with a lot of communities, especially communities of color and the public health sector. So, and unfortunately, I had the opportunity to talk to an epidemiologist who's been tracking all of this for Maricopa County, and there's not much being done to address the rebuilding of that trust through education. So I know there's been a lot of push to look there. One of the vaccine developers happens to be a Black woman, but there needs to be more communication. So this epidemiologist could, just to tie this up, they are very much aware of the missteps that have happened in the past to cause this this tension and this mistrust, but there's still a lack of communication of just just the basic biology, the understanding to give these communities the information that they need to feel better about going out and getting this vaccine. So stay safe, everybody. Wear your mask in public spaces and practice proper mask wearing. So one of the new things that I came across was don't touch your mask with your hands. When you're putting it on, use the earpieces to put it over. Make sure it's covering both your nose and your mouth. Wash your hands before you apply your mask and after you apply your mask. So if you do happen to have COVID or the SARS-CoV-2 virus and it's shedding through your nose and your mouth and it gets on your mask and you're touching it with your hands, then you're going to infect surfaces that you're touching with your hands. Wash your hands. Please, if you have the choice between washing your hands and doing sanitizer, wash your hands. It's incredibly effective. It takes about 20 minutes. Make sure you're getting all your hands, but sanitizer should be used if you have no other option. It definitely leads to, some scary resistant microbes. Plus it kind of or at least I think it just disrupts the microbiome that's on your hands. So definitely keep washing your hands. Stay 6 feet apart. If you can't, make sure you're not standing closer than 6 feet for more than 10 to 15 minutes. And limit social gatherings. I know it's really hard, and this has just been an unprecedented year, but it's unfortunately the best option that we have. And if you're suffering, reach out to your loved ones, to your community. We're all here to, we're going to get through this together, and we need to be there for each other. So with that, here are some references, and I think that brings us to our Q&A.
It does. Thank you so much, Amber. And let's go ahead and call up everyone so we can start launching right. Make sure I go through and ask all of the questions that have been posted in the comments because I think it's clearly pointing towards the concerns that exist within the community. So just starting from the bottom, because they relate to what we just heard, I want to go back to the concern that has been expressed about mistrust within particularly the Black community. And Amber, maybe we can talk about this with you a little bit. We see so much being done to sway some of the conspiracy theories and majority groups when it comes to the COVID vaccinations. But in particular, I think it's arguable that Black communities have justifiable concerns when it comes to anything like this. We have the history of the Tuskegee experiment, Henrietta Lacks, and just the history of experimentation and things like that within the Black community in particular. So let's go back to that question of what's being done to address those concerns. Let's start there.
I really don't see much being done to address it. A lot of people in the scientific community, they are aware of that history, but I don't think I think they're going about it all wrong, especially with, like I was mentioning, it's just like, oh, well, one of the developers is African American. Well, you should go get it. Well, you also haven't explained anything to me about, how is this vaccine developed? Why should I trust a vaccine that, seems to have been developed overnight? So I would love to see more communication, and not necessarily, symposiums for scientists to go to and, talk up their jargon or anything, but, boots on the ground, understanding what information do we need to relay to build that? Because there definitely needs to be a conversation, and there hasn't been from public health agencies and the Black community. Unfortunately, it's just like the attitude I get is we've addressed those issues, so now the process has more like guidelines to make sure it never happens again, but there's no conversation about why we should trust them.
You talked in your presentation a bit about the diversity of COVID-19 vaccination trials. And one of the questions that was asked was, were there enough Black people in the trial to determine if it will be safe for Black people?
That information is really difficult to find. All I was able to find was Moderna mentioning the out of that 196 who contracted COVID, I believe like 33 were Black. But that's historically been an issue, is, underrepresentation of communities of color in science and like basic research trials. And so unfortunately, I'm not able to answer that. I mean, I know they included them, but they weren't forthgiving with that information.
Okay. Next, we have a couple of related questions, and I'll ask this for any of the three of you that have insights into this. There's been so much concern over how quickly these two vaccines were developed. And so the two questions from the chat were, why should we trust it since it was developed so fast? And related to that, since they developed this so fast, did they cut corners? Why were they able to do it so fast? And related to that, I think we also go back to the common question that comes up with any of these sorts of vaccines, which is, it's often stated that, they could come up with a vaccine for this and do it this quickly, but we don't have a vaccine for something like the common cold. So all of those questions, I think, really kind of go together as far as the timing, the speed that this happened in, and I think it goes towards that question of trust when it comes to being able to trust this vaccine. So if any of you can speak to that.
I'll take a go at it. So thank you, Ms. Jones, Mr. Barkley, for your presentations. It was really interesting to hear the different information. So again, really pleased to be part of the panel. So I'll say, and I agreed with the assertions that Ms. Jones made in terms of, trust and communities of color, but I'll put a different spin on it. I also think that as people of color, we're incredibly resilient. And I do think that communities of colors are being invited into the conversation. We're having forums like we're having right now all over the nation. And that's what works, and it's helping, and we're getting out there. You have a group of professionals with you involved in the sciences in various ways today. And so through these forums, is it enough? Absolutely not. But are we trying to do our due diligence? I think we are, and I think public health entities are as well. And so I would just offer that. In terms of how did it get produced so fast, that is the $1 million question. And so what I will say is a lot of the science that has been is backing this particular vaccination has been in place for decades, and that researchers have been working on vaccinations like this for decades. And so it is quick to get it through the approval processes and clinical trials. And so there is still concern, and people certainly need to work with their physicians. But it did not just come under the cover of darkness. And I think that's something as scientists and researchers we've really got to help dispel, is that, and not only that has it been worked on for decades in terms of laboratories and perfecting vaccine protocols in general, But because it is a pandemic, we have the brightest minds across the globe working on this, not just the brightest minds in our country, but across the globe. And so for me, that helps as well, because I do think the participation in the vaccine trials has represented a lot more communities of colors, perhaps not just African American, but by minorities in other countries as well. And so I do think that that is refreshing. Now, does that mean that there aren't concerns? Does that not mean we shouldn't ask questions or work with physicians? Absolutely not. And to get back to building the trust amongst people of color, that is what the United States almost single-handedly alone needs to take on in terms of getting herd immunity and getting people of color across our nation to trust the vaccine.
Going back to the social determinants of health, I think something that we're seeing from the audience and messages that are coming in separate from the Facebook stream, but still asking some of these questions are, we look at those social determinants. We look at the statistics that say that Black people and other communities of color are 2 to 3 times more likely to catch this virus, almost 4 times more likely to die from it. And yet, I'm looking directly at one of the questions. It just says, so Black people are among the most impacted, but were not included in large numbers in the vaccination trials. And that's concerning. So I think we'd like to talk about that a little bit more and just talk about why is there that discrepancy in what we're seeing in the information that's being provided.
Yeah, and that's hard, right? And that kind of relates to the last couple of questions. As historically, we as African Americans, as Black individuals, and especially Black women in particular, have not been included to the extent that they should be in medical, psychological, what have you, in research, in public research. It really wasn't until very recently that started to really at least be called out, and hopefully we get a little bit more transparency on the amounts of our people who were included in the trials. But I think it comes down to priorities. You've got to keep in mind with the COVID-19 vaccine trials in particular, because the need was so high and so great, they had to move really fast. And that kind of goes back to the last questions of how did this happen so fast? Well, the need was also really high. Just the amount of fatality, not only in the US, but across the world, I think is what really drove this process to be sped up. And it can be hard to get participants for studies like this, right? So it's a double-edged sword. So on one hand, we aren't generally asked to participate in these studies, but on the other hand, as Black people, speaking as a Black person myself, if I were to be approached to take place in an experimental study for a vaccine, would I be super eager to do it knowing the history of experimentation on Black people? No, I probably wouldn't. And so there just has to be a lot more truth and reconciliation, I think, before we can start seeing that gap bridge. Going back to the question about, what's being done to get our community specifically more comfortable with this vaccine, I think first our leaders have to acknowledge the fact publicly that our history has been very traumatic towards people of color in the field of medicine. And I don't know that we've necessarily seen that from higher up leaders in this conversation. So it kind of creates this feeling of being gaslit, right? Like, oh, that's a long time ago. It's not really a problem. So, take this vaccine, it's fine now, right? But if you don't acknowledge the trauma and where we're coming from, we're not going to participate in the studies, and you're probably not going to want to ask us to be a part of the studies. So it goes back to first addressing the trauma in the first place before we can really make those strides to increase our numbers of participation, I think.
Yeah, I want to stick with you, actually, because we did have a question come up, and you referenced it earlier and you referenced it just now, about the health inequities between Black women and their white counterparts. Can you speak a little bit more about that?
Yeah, it's interesting, and I wish I had some of the the studies with me, but it's been a conversation in recent time, specifically on the ways in which Black women are treated when they're in the doctor's office, when they're reporting things like health issues, pain, and how that's perceived by a doctor. It's less likely to be taken as seriously. Black women are less likely to be prescribed stronger prescription painkillers like opiates, because chances are they're just not being believed at the same levels when they're reporting what's going on with them. When you take a step back and not just look at Black women, but women in general in the medical field, something that I think is interesting is the field of heart attacks. So women report different symptoms of heart attacks that are still symptoms of heart attacks, but the training has not necessarily been caught up to speed in the medical field. So you can have a woman, especially a Black woman, come into the doctor's office, and there have been reports of a Black woman saying, "I think I'm having a heart attack," and they'll report their symptoms and they'll get sent home. There was a study published, I think, about 4 or 5 years ago that showed some bias where some newer physicians thought that Black individuals had a higher pain tolerance, that perhaps their skin was a little tougher when it came to things like vaccinations and puncturing their skin. And so there's just a lot of catching up to do in the medical field, but particularly with Black women, because it's that double edge of not only being a woman, which has been a historical story of disparities in medical research, but being a Black woman, when you add that other intersection on top of that, there's just not a lot of inclusiveness in the research behind health for Black women in the way that we treat our Black women when they're reporting problems. So,
well, I'm really glad that in this conversation we're having today, we have two very knowledgeable Black female leaders who are able to speak to these things and are speaking with us and our community today. Dr. Peoples, I want to go back to sort of the beginning with all of this to talk a little bit more about how COVID is caught or transmitted. I think even now, after almost a year of living through this pandemic, many seem unclear about transmission methods and mechanisms. So can you share a little bit more about that?
Sure, I'd be happy to. And we're still learning more about that. I forget the actual week that we were within the COVID pandemic before the CDC fully shared the information that it was airborne and that you could catch it, and that, just through being in common spaces with strangers and still being physically distanced, and therefore we really needed to have a mask, not only to protect ourselves, but to protect others. So having said that, it is transmitted on surfaces as well. Different studies show different results and outcomes for how long the COVID-19 virus can live on a surface, but we do know it can live on a surface, which is really where the restaurant protocols and protections, our fitness centers, gyms, childcare, where we're seeing clusters come into those places, and where we're really asking people to be mindful of their surroundings and to be able to not just trust that something's been disinfected, but to take that extra step and to do it for yourself and to make sure it's disinfected for the next person perhaps coming after you. But so it is transmitted through common touch, through air, as I shared. And then what we're really seeing is that when clusters occur, of course, whether it's in the workplace, whether it's within a child care setting, or within our own homes. And that has really been the problem, I think, in terms of communities of color, and certainly what we've seen within our own county, just with tribal nations as well, is that, most people live in confined spaces and don't have, I don't know if I should say the privilege or pleasure of not living with other people, because we need that community as well. But, when we have somebody in our immediate family that does contract COVID, most of us can't just sequester them off. We have to share kitchens. We have to share restroom space. And that is where this has just continued to go and go. And that's, again, why Ms. Jones' information was so helpful on the vaccine. We really have to reach that herd immunity. And therefore, give my spiel again, that public health officials, government officials, myself, you all, we've got to do what it takes to build that trust within communities so that we're not afraid to get the vaccine.
You spoke earlier during your presentation about the mechanisms being put in place to ensure that folks are receiving both doses, and you expressed some concern about that. And I know there was just this week a presentation by Dr. Kara Christ talking about the potential for a tool being used to both sign up to get the vaccine and then to get reminders. But are you aware of anything like that for whether it's within the state or within the county or locally that's being put in place to help with that?
So I'm not, and that doesn't mean there's not those tools being put in place, but I'm not aware. And actually, I would call on more grassroots efforts, whether it's our church communities, our fraternities, our sororities, to be my sister's keeper, be my brother's keeper. I believe it was Mr. Barkley that mentioned in his social determinants conversation, lack of transportation, lack of infrastructure. I am really concerned. I think people will show up, perhaps not the numbers we want, but people will show up to get that first dose of the vaccine. And then not because they don't want it, perhaps not even because they're mistrusting, they're not going to have the means to get that second dose. And I do think that is where state officials, candidly speaking, are failing. We're not taking that next step to make sure that people have the tools in place to get that second dose, and we need that. Whether there needs to be incentives to get the second dose, and I don't know what that means or what it looks like, but we have got to make sure that communities, particularly vulnerable communities, which again, people of color, elderly, kids, that we are making sure and following them through that vaccine protocol. So I am concerned there, but I do think there's a lot of space, as I mentioned, for church groups, fraternities, sororities. Much like we roll out the vote and make sure people can get to polls, we've got to make sure people can get back to their vaccine.
We had a question from an audience member that specifically asked, in the dental field, it has been a concern that we are not considered essential. Where would we fall on the phase for the vaccine?
It's a great question. I'll need to look at, I've got some more detailed notes on who falls there. But just on the face of the question, I would think dental workers do fall within that essential phase one. And so let me check, and I will get back with, I guess, Ms. Bernadine, Ms. Deb, somebody, but absolutely, our dental workers are essential. And we also know, I'm sure Ms. Jones could talk about this more, but social determinants of health. Poor dental care is one of the primary ways, whether it's heart attacks, strokes, other, pre-pregnancy issues. So people of color, again, need dental care, preventive and acute emergent care.
Thank you. And for any follow-up information that we get on any of these topics, we are happy to post that into the comments for this thread so that folks can come back to that and find that information. So thank you. Mr. Barkley and Amber, I want you to know I am not skipping you for questions. I do have some coming up for you, but I'm going down in a little bit of an order here, so I'll come back to you shortly. But Mr. Barkley talked about the connection of stress and racial disparities and racism to determining Black health during your presentation. Can you expand a bit more on the impact of mental health and stress when it comes to facing a community crisis like COVID-19?
Sure, that's a big topic, and I actually think Dr. Peoples also touched on it a bit when discussing kind of what missing piece we're missing in our response to COVID-19, and that's that mental health piece. Look, I don't think it's any secret that this year in particular, we've seen a kind of a reckoning with racial injustice that we perhaps haven't seen in the last few decades, in terms of the big public push by a multitude of generations to demand for equity and justice. But that didn't just spring up out of nowhere, right? It's a result of videos of police brutality, of disparities brought to light by COVID-19, and this year, and really the entire experience of Black America, but this year in particular, has really shined a light on the stresses of being Black in our country, on the stresses of living with police brutality, on the stresses of facing discrimination in these systems that could mean life or death. And so the stress of living day to day and having to consider your safety, having to constantly be conscious of whether or not resources are going to be available to you. It has as a physical impact on your body that stress it does physical damage to your body, but it also affects the way in which we communicate with our communities, right? And the way in which we interact and get involved in our communities. When you feel disenfranchised, it's really hard to motivate to then participate in these systems, to demand justice, to get out and vote. Thankfully, we saw a huge rise in voting numbers, during this last election, and that was something to be very proud of. But when you feel so chronically disenfranchised, and then you're hearing, you got to get the vaccine for the greater good, and you got to go back, but we're not necessarily going to do much to bridge these historical gaps that are making it difficult for you to do so, it's going to make you probably a lot less likely to participate in these systems, right? In these community systems, to go to the doctor's office, to drive the 3 hours, depending on where you live in Coconino County, to go participate in a vaccine that you're scared of, that you have a lot of anxiety about, that you're maybe not getting treatment for. And then you combine that with the isolation of COVID. A lot of us are feeling a little isolated from our people in our communities. And so we're not having these conversations as often as we could on, are you getting the vaccine? How are you getting there? How are you feeling? And so like Dr. People said, I think it really does also need to be a grassroots effort of us as leaders in our community to check in with our neighbors, to check in with our friends and our loved ones, to be that little extra push for them of emotional support. Hey, I hear your anxieties about the vaccine. It's valid to be scared about the vaccine. Here's the information that I know. What can I do to help you get this vaccine, to eliminate the barriers? Because if that doesn't happen, folks are isolated, and it's hard to motivate and get over that emotional hump to do something that's ultimately pretty scary. It's the same thing with conspiracy theories, that I think that we have to have a discussion on how we address them. Because if we just shut them down, no, that's ridiculous, that's dumb, that's harmful, usually what that results in is people locking up, right? And maybe holding on to that belief even more. And so if we have someone who comes with us and says, I'm really anxious about the vaccine, and here are all of the wild things I've heard about the vaccine, our response can't be, no, that's silly, that's ridiculous, just get the vaccine. We've got to approach it with some empathy and compassion, and we've got to be proactive in our community about that. Got to reach isolated, make sure we can see how we can eliminate some of those barriers.
Thank you, Amber and Dr. Peepers. I'm going to ask you to speak to this one as well. We've had a couple questions come up when it comes to the cost of the vaccine. And I think it's a dual question. So first, and Amber, maybe you can speak to this since you gave us that background on the development of it. What has been the cost of developing the vaccine? And then on the second side of that, I think, is the question of what will it cost people to be able to get this vaccine?
Yeah, of course. So we saw that number of $6 billion that went into developing it. So it's very expensive. And I can speak more to just the research and development side of it. Is, you have a lot of really expensive instruments, a lot of really expensive reagents and everything that you have to do. But then you have the cost of just manufacturing it also. So once you have spent the money to develop it, then you have to put a lot of money into, getting those clinical trials up and going, and going through the approval process, and then of course scaling it up so you can manufacture millions and millions of doses. From what I understand, and Dr. Peoples will be able to speak to this more than I can, but from what I understand, because it was taxpayer money that went into the development, that it will be free. So it shouldn't cost anybody anything, but that doesn't necessarily mean that the providers giving the vaccine can't charge a fee, is how I understood it.
So that's exactly right. People need to ask questions. They need to be cognizant of the service that they're getting. So much like COVID testing, so the county's COVID testing has been 100% free. There are no charges. There are no questions asked, other than your patient questionnaire, but we don't care what county you live in, what jurisdiction, it's free. However, what we saw with other places across the county, whether it's physicians' offices or other pharmacies, whether it's your box chain ones, your CVS's, your Walgreens, they may offer it for free, but they charge the laboratory service fees or their administration fee, and those costs can add up quite a bit. So the same is true for the vaccination. It is 100% free from the county as long as you're in one of those phases, and as the rollout goes along, it will be free. But our partners that we are rolling this out to as well, they're allowed to get it through the federal government, of course. So again, those same big box pharmacies, the vaccine itself is free, but they will be charging their administrative and other fees. So people need to ask. And to some degree, that's okay, because public health isn't going to have enough capacity. And if people have insurance and their insurance covers it, then great. That's what insurance is for. But those are the questions to ask if you're going to go into a Walgreens, a CVS, a Walmart, a Sam's Club, wherever you're going. You want to make sure that you know what your out-of-pocket is going to be, and you should probably have a conversation with your insurance company to make sure that they are covering it.
And if I could just piggyback on that, I think we also have to be cognizant that even if there's not a direct monetary cost to pay for the vaccine, just the act of transportation, of missing work, perhaps to go get the vaccine and then having to go back again does present some cost to a lot of folks that we might take for granted. And so when we're thinking about ways to support folks, we want to make sure we keep that in mind and are cognizant of that, because that's the social determinants, right? So it's maybe free of cost, they're not paying for it, but it's going to cost them something. We want to make sure that we're addressing those barriers too in whatever way we can.
Thank you all. As we are drawing close to the end of this conversation, I want to go back to the question of social determinants and just talk about what we as a community can do to address the social determinants of health impacting our community, and how can we pull together to ensure equitable access to the resources needed to protect not only the Black community, but communities of color and our broader community as we work to address that. And that's a question for any of the panelists.
Yeah, does anyone else want to jump in first? I'm curious to hear your thoughts as well.
You know what? You two are younger, and you are going to be leading us. So I want to hear what y'all have to say.
Sure. Well, I love the question. I mean, I think obviously it starts with things like this, right? Having the conversation in a public forum where folks can participate, that's accessible, so folks can be educated about what the issues really are and how they affect us. But at the end of the day, I think it's holding our public officials and our systems accountable, right? We've got to be honest and set our standards, and then in whatever way we can, make sure that individuals who are making policy, who are building these systems, are in line with the standards that we as a community think are important. And that comes in voting and participating in voting. And if there's not a candidate that you feel meets those standards and has those priorities, it means being involved in running yourself or running someone else that's going to make those priorities front and center for you. And then I just think it comes in organizing. We want to change the systems that have created these gaps. That takes a lot of time. In the meantime, what we can do is locally, we can support one another, right? We can do kind of a mutual aid thing where we make sure people have transportation. Maybe their health insurance doesn't cover it. Maybe they can't afford a taxi. Maybe they don't have a car. As a community, we've got to come together and pool our resources, right? So not only do we need to vote to change the system, do we need to protest to change the system, but we can also start doing some of those changes now without relying on the system to fill those gaps. We can make sure people are fed in our communities by checking in with our neighbors. We can make sure people have transportation to their doctor's offices. We can pull in our monetary resources wherever we can to make sure that those gaps are being filled as a community without relying on these systems to do it for us.
Amber, any thoughts on that, or Dr. Peoples? Go ahead.
I don't know if I can top that, but I love it. I love it so much. And I love this idea of, it's going to need to start, I think, as a grassroots movement. So definitely checking in on your neighbors, checking in on your friends or family, understanding where those gaps are, because those might be different, from person to person, and making sure that we're addressing those. And definitely education. I'm really big on, making sure everybody's educated on this, because it is moving really fast. I mean, the story is being added to, within hours. It's really kind of crazy, but to understand it and then be able to battle, that misinformation, have that conversation with somebody who, I've heard this and I'm really scared, like, let's talk about it. So yeah, I really love all the comments that have been made on this. I think it's, yeah, stand together and, build that community, make sure everybody's taken care of.
The only thing that I will add to that conversation is get involved in your local government. There's many cities and towns across Coconino County. So for this conversation, I'm sure most people, it's, City of Flagstaff or Lee County. But we are all collectively one. And again, there's many cities and towns. And if the pandemic has any silver lining, it has been increased technology and increased transparency, across governments. There is no reason not to tune into your local city council meeting, your weekly board of supervisors meeting. There's a lot of information shared, and there's always opportunity for public commentary. And if there's anything that makes me sad about those events, and yes, they can be long and they can be boring, but there's very rarely anybody from the community participating or logged in. So, you're at home, you're watching TV, you're folding laundry, tune in, have the city council, county meeting playing in the background, participate, be knowledgeable, be informed, and share that information.
Well, I just want to say again, thank you to all three of you for speaking with us today and providing this information. This has been so insightful and so educational for our community. And I know that there are still so many concerns, so many questions that exist out within the community, but it's sessions like this and community dialogues like this that provide resources and opportunities for people to be engaged and get the information that they need. And we thank the community as well for tuning in and being part of this conversation. We encourage you, because of how important this is, not only this session, but all of the sessions that we've had, but in particular with this one and covering the topic of COVID-19, to please share this information out to your networks, whether that is sharing the link to this Facebook conversation onto your pages or within your networks. This will be posted to the Murdoch Center YouTube channel. So please share that out, and not only to your local community, but beyond to your friends and family who are outside of the Flagstaff or Arizona community, because this conversation, as was said earlier, is one that's happening nationwide and is so important for most people and for more people to get this information, to be part of this conversation, and to share these resources and this knowledge out within our communities. Ms. Bernadine, I turn it back over to you.
Absolutely. Thank you so much. I think today's discussion is only the tip of the iceberg. I know for a fact that we could go on for at least another hour talking about, because just in the last moments of this discussion, we talked about, and thank you, Dr. Peoples, for bringing that up, about getting involved in community policy and the process. And then I think both Ms. Jones and Mr. Barkley touched on the importance of grassroots action, right? And so as we come to a close, my final thought was, no man is an island. We are all interconnected. And we do these broadcasts, we're doing this Lived Black Experience project because We talk about informing and educating and enlightening our European brothers and sisters. And I always like to say we're not looking for allies. At this point, we need some accomplices. And so, when we talk about, giving the rides and providing meals and being, I also think about being understanding. Most of the community or a significant part are local business owners. So being empathetic and understanding and being willing to give that time off, and encouraging your team members that are a part of your business to have that time off to go get the vaccine, to go take care of your family, to provide a ride, some extra time off to take care of self. And this is where we, as people who are walking around in this melanin, we'll work. We work until we die. That tends to be our work ethic. And not saying that that's bad, but it is in a way. So it's good to be loyal, but to not work ourselves to death. And typically, this is what we're seeing. So no man is an island. No one is entire of itself. And every man is a piece of the continent, a part of the main, including we as melanated people. And so, Flagstaff and all of our viewers, as we come to the end of this Hot Topic broadcast, we're not asking for a seat at the table at this point. We're in the kitchen, we're providing the meal, and we're coming out and we're taking our place among you and offering you this meal to share with us. So with that being said, please stay with us. We'll be back. We'll keep doing these. We need to have this conversation and take it further. And I'm sure maybe in a couple of weeks, we need to come back with maybe an update on more about the vaccine, because we didn't even cover. We're waiting for more. We don't have enough to vaccinate everyone. So, I mean, that's another deep conversation that I'm sure we'll be back to have. Until then, everyone, thank you, panelists. Thank you. Just thank you for the work that you're doing. And continue to be healthy, be happy, be safe, and we'll see you again. Go in grace.